Precision medicine is a term, a buzzword that's been used all over. But I think you'll see from these next three panelists that precision medicine is happening. And each of them will show you a different perspective. We have Kathy Giusti, who is the founder of the Multiple Myeloma Research Foundation. And she's also holds the Bob Kraft Precision Medicine Chair and Accelerator at Harvard University, which she runs. We have Athman Laraki, who's the co-founder and CEO of Color Genomics, and Vijay Pandey, who's the general partner in the biofield, and Andreessen Horowitz. And each of them are going to build or bring a different perspective. So we're excited to talk to them now on stage. All right, so precision medicine has been this buzzword for a long time, and we've been talking about it over and over again. Is it real, Kathy? Are we doing it?
Yeah, I definitely think we're doing it. I think because we can now sequence the genome, because we can now share data in the cloud, because patients are starting to understand it, I think we're making unbelievable progress. I do think that some cancers are making much more progress than others. And I think there's still a lot to do, but I think, I think it's incredibly, incredibly hopeful.
Should every patient have their genome sequenced?
I believe so. And I think that what will happen over time is the more you know about your genome, your subtype, that, everything changes so quickly that at least you know that, and you know how your tumor changes over time, so that longitudinal information is helpful as well. So if you know that and then new drugs are developed, then at least you've got a chance at getting them. But I will tell you, we did a survey across 5 different cancers, and the awareness of precision medicine, when we said, do you know what it is, was in the low 40s. So I think there's an element of coaching and training patients on, why do you want to get to an academic center? Why do you want to get genomic testing done? What do you need to know about it? What do you need to know about your subtype? Because it can all be a little overwhelming right when you're diagnosed.
Oh, I get it. I mean, the notion of actually seeing what drives the cancer and being able to target it is very powerful. Color genomics has obviously a very different focus than patients with cancer. And they've got this lofty goal of potentially prevent cancer. When Angelina Jolie said, I have this mutant gene for breast cancer, BRCA, it was $5,600 for a woman to have the right to look at her own DNA. She had to pay a ransom to look at her own DNA. And you guys democratized it, liberated the ability to look at your own DNA. And to that, I applaud you. Why isn't every person in the country being sequenced for BRCA?
Yeah, it's a great question. I mean, I think it's a progressive thing. I mean, to your point, I think earlier there was a huge cost barrier that dominated the rationale behind how you think about using genetics. So in a world where testing costs, $5,000 or more, you just realistically cannot make it available to everyone. And I think that wired everyone to think about genetics as this very expensive, high kind of cost, both financially but also, from a process standpoint, thing to do as part of healthcare. And I think the thing that's been interesting the last few years, when Color launched at $250, it allowed us to start walking down the path of, changing the entire rationale of how we think about the use of genetic information, and going from this thing that's, used at the end of the chain only after a family's had a lot of disease in their family to try to explain why bad things happened, to now start thinking about this information as something you do at the very beginning, right? Like it costs potentially less than a mammogram, right? And so, I think now we're at the point where it's literally ROI positive to sequence the entire population. So I think we're now in that major transition phase where kind of the medicine as well as the kind of cost structure have caught up. And I think the big step that's still remaining is a convenience standpoint. It's still, I think, quite inconvenient for people. And that's one of the big barriers that Color's also been working on, is how do you just make it really simple and integrate it into normal practice.
So this predatory practice that basically happened before you came along, and also I should say what happened in the middle was that the patents, you can no longer patent a gene in our country, and that certainly helped a little bit. But this predatory practice, this monopolistic concept, if I can charge whatever I want, we see it in cancer drug pricing, we see it potentially in cancer genomics. I mean, there's no reason per se that it needs to cost thousands of dollars. It could cost hundreds of dollars. How can you do it, but others couldn't?
I mean, I think in general, I mean, I think one of the general issues in healthcare, or one of the challenges, is that they're almost monopoly pricing or monopoly power through the entire chain, right? You know, going from payers all the way to pharma and to diagnostics, et cetera, where, you know, the value that's being delivered and the, you know, market power does not propagate from consumer all the way down the chain. And I think one of the things that, you know, for us that was a kind of competitive advantage is, you know, we came in with a very heavy tech background. So a lot of the people in the company had very deep machine learning backgrounds. We were kind of from more kind of the tech side. And we were fortunate to, you know, pair with people like Mary Claire King on the genomics side. But we weren't beholden to the, you know, the system, if you will. You know, we were able to kind of start almost with a blank slate and use the technology that was there almost from first principles, as opposed to try to work from an existing model backwards.
So for those of you who don't know, Mary Claire King is like the godmother of genomics and helped discover all these breast cancer genes. So she is the hero in the field. So there ain't much better to work with than she is. So Vijay, you know, over the last 20 years, the capital markets have kind of closed down to biotech. And it's not the hot thing anymore. You know, all of a sudden you can start an internet company and be public 3 years later. How did you go into biosciences? And Andreessen Horowitz, one of these big tech investment funds, venture funds, how did they allow you to do bio?
Yeah, actually, you know, it's interesting because things are turning upside down in terms of exits, and that a lot of these tech companies, like storage tech companies like Airbnb, are taking longer to go public, and there's strong reasons for that. I think actually, really the opportunity that we saw was actually not so much in terms of exits, but in terms of how you build companies. You think about Color. Color is a great example of a company built like a tech company, but in the biology space. And we've seen several of them, and I think the future of precision medicine will be incorporating these tech advances, like machine learning, where we're not just talking about, do you have a gene that might make you, might lead to breast cancer, like Angelina Jolie, but for example, looking at your DNA in your body to say, do you have breast cancer right now at early stages, such that she wouldn't have to remove her breast prophylactically. I think these are opportunities that only come when you can combine best founders that have deep expertise in the machine learning side and deep expertise on the bio side, and that's the opportunity.
That's great. The you know, the field of business and training young entrepreneurs, business people, you know, we train them to think about best practices, about corporations. Do we train them all on the bio side?
Well, I think we have to teach each other how to do this well, and I think you know, there's the element of the science, and then there's the element of how you bring business policy to make the science and the technology happen. And I think for us, and we did have a lot of success in multiple myeloma, launching, you know, 10 drugs as a foundation and really extending the lives of our patients. But we were hugely frustrated that we didn't have data, and we couldn't, way back when, get the academic centers to provide the data we wanted to find the targets for precision medicine. So we had to put all of that data out there. And even as we did that, and we were having this discussion in the green room, but even as we put all the data out there, what we realized was everybody was using the data. Any scientist can use this $40 million data set that we funded. A lot of it was just happening, you know, at ASH and ASCO, and yet it wasn't changing what was going on with our patients. And it wasn't necessarily changing how we would identify and validate the best targets still that we needed to focus on in myeloma. So we ended up having another business philosophy where we had to put more funding out there and say, okay, now we want all of you to play and apply together to validate this target, to validate a high-risk signature. And you keep having to put money and project management into the pot to get everybody to keep coordinating behavior. And we're finally there, but I will tell you, it takes some heavy lifting. You know, and what we found was even though we put $40 million into a data set, it was hypothesis generating. It wasn't enough to validate. So even in our, you know, tiny cancer, you know, I still need to go over to Lori Glimsher at Dana-Farber and say, you've got a great data set. Can I have that? By the way, could I give it to Colin Hill at GNS? And could he, because they're not going to hand me their data set at the MMRF. So what are the business models that will create that? I want data, I want to know the target, and how do we push forward? We've identified a lot of them in myeloma. So we know BRAF, we know FGFR3, and we've moved forward and done, you know, precision trials around all of those and made a lot of progress. But we still have a ways to go. And I think immune will be an entirely new space for us where we go, what data are we collecting, and how do we really start to do this well?
So, patients are heroes who say, take a piece of my tumor, or I'm even going to allow you to do another biopsy so you can actually look at the DNA. When patients do this, and then an academic investigator, this is my data set, it's my data, I want to use it, and I'm not going to let anybody else because my career depends on it. Should all data be liberated? Should all data be open source? It's the patient's data, after all.
I believe so, and I think you have to find ways to do that, because I get it, an academic center, this is their gold. Like they've put a fortune into it. But I do believe you can set up these situations where we set up one called the Answer Fund, which is you put the question out there. Another example we had was, myeloma patients don't want to be on maintenance therapy. Payers don't want to pay for maintenance therapy.
So maintenance therapy is after they go into remission from chemo, you keep them on a drug.
Yeah, you keep them on the drug. And you could be, as a myeloma patient like myself, I was in a complete remission. I had no idea how long should I stay on maintenance therapy. Was it really required? And it's not fun to be on the drugs, and it's expensive to be on the drugs, but nobody knows the answer. So we realized by doing a crowd program with our patients, that was the #1 question they had. Now you've got to bring all these data sets back in together, because we didn't have enough data, again, to answer that question, because it's not necessarily like the pharmaceutical company wants to say, well, I don't need to have you on maintenance therapy anymore. So I think we have to come up with creative ways where data gets aggregated and data gets analyzed. And interestingly for us, we found that by going out to the machine learning companies and saying, this is the question we're trying to answer, can you help us and apply with the data set you know, then we could find out who was willing. And then if an academic center didn't necessarily wasn't part of that, then we go back to them directly and say, would you put your data set in to answer this question?
One thing just to interject here that I think is really interesting is, that's two things that I think are going to change that a lot in the next few years, and have already started, is one is thanks to wearables, and genomics. I think all of a sudden, it used to be that most of your health data was sitting in an EMR somewhere, and it's out. It used to be a filing cabinet. They put it online, called it an EMR, but it's still a filing cabinet when all said and done, and out of your reach. And I think now that's, between your genomic as well as kind of wearable data, all of a sudden there's a pretty heavy amount of data that's completely health data that's in control of. In the hands of consumers.
Yeah.
So along with consumerization of healthcare, I think, one thing that we've seen with color is like, everyone who takes a color test, we give them the option to contribute their data to research anonymously, and we get, in the like 70 to 80% opt-in rate. And I've heard that across a number of different services. So I think people are very willing to do it. And so, as these services become much more accessible, I think that's going to become just, standard practice. Like I think it's going to be much more the exception.
Why are the 20% saying no?
I think for some people there's a fear of their data being misused. Obviously, every few months we'll have a story around privacy issues, whether it's in healthcare or in Equifax, et cetera. So I think there is a certain level of concern around how much do you trust a company to make your data available. So I think that's probably one of the bigger hurdles. But I mean, the 80% is still, I think, huge value. So,
Is data security something you guys are looking into on the health side?
Yeah, I mean, information security in general is an issue, and I think data security is generally handled very well in companies with a HIPAA and so on. So I think that part is not a concern. I think what's interesting is that patients can own their own data.
So HIPAA's not data security.
Yeah, that's true. I mean, so is data privacy. But I think when patients, so data security internally, I think is part of just information security in general. In terms of data security for patients, what's intriguing is that patients are allowed to have their own data. And then the question is, what do they choose to do with it? And are they informed such that they know what they want to do with it?
If I were running a color genomics, I would be awake all night thinking of what if a woman took the test and didn't understand the results? How do you know that someone is going to do the right thing or really understands it? And how do you sleep knowing that they may not?
Yeah, no, it's a great question. It's actually something that we spent a huge amount of time thinking about, and especially in these cases where you're fundamentally dealing with a statistical answer, right? You're and ensuring that people really understand what the information conveys, and for example, especially telling someone that they're a negative, making sure that they actually know that doesn't mean that they're not going to get cancer, and that they should, and so that's something we spend a huge amount of effort, on both on the comprehension, but also surveying people afterwards. That's also why we include genetic counseling with every color test as part of the service. One thing that's kind of interesting as part of that too is that we actually almost like, I think, half of our GC time is spent talking with doctors, educating doctors about this information, because now the majority of doctors who are using genetics today are no longer your cancer docs, right? You're starting to see many more OBs and GPs that are using this information, so ensuring that they understand what this information means and what the follow-ups, that follow-ups that should come out of it.
And we're not obviously trained in that. I want to go to questions in the audience because I want to kind of bring in everybody to the discussion. Yes. A mic is coming at you. Duck.
Valerie Montgomery Rice, Morehouse School of Medicine. And so, Ahmed, I would like for you to share a little bit more about how you move beyond just democratizing access from the cost, but what type of partnerships you've done. And I know one of them is with us, but with others to really make sure that these genetic tests are accessible to many other women.
Thanks for the question. I mean, that's something that we spent a lot of time thinking about. I think one piece is, maybe I'd break it into like 3 big categories. One is kind of democratizing in terms of like relative to social, categories, whereas whether it's, in cases of minorities or, historically most of the people who had access to precision medicine were wealthier people, so kind of ensuring that, that there's an opportunity for access, across different levels. So one of the areas is working with, Morehouse and a number of other centers. I mean, so we have a program called we used to be called the Every Woman Program, now it's called Color for All, but where we offer subsidized testing for larger populations. That's one category. Second one is around research. I think, historically, a lot of the scientific data that's used today is around essentially Caucasian populations. I think there's a lot of value in incorporating into these large research data sets non-Caucasian populations, and so that's something that I think is quite interesting. And then the third part is thinking outside of the U.S. When you think about developing countries and less wealthy countries, like you'll have, for example, if you look at Nigeria, I think literally there are fewer oncologists in the entire country of Nigeria than there are in San Francisco. And when you think about a situation like that, the question is, how are you going to deal with the burden of cancer or the burden of heart disease, as the population ages? And there, I think, really working with health systems around having a prevention-first strategy that's less about, waiting for people to be damaged to try to do something, as opposed to, really using this information for prevention from day one. So I think those are kind of, the big ones for us.
Thanks. We have another question.
I wanted to support what Kathy said about sharing data and how important that is. We do offer every single patient at Dana-Farber the opportunity to have their tumor sequenced. And about 85% of them say yes. And those data get deposited in a consortium of cancer centers. There are probably 15 of us now. And the reason that's important is, let's say a patient has a rare mutation, and there may only be 3 or 4 patients at Dana-Farber who have that mutation, but we can go into the database and find, well, maybe there's 5 people at Memorial Sloan Kettering or 3 people at MD Anderson. And together, when you put those patients together, now you have enough patients to do a small phase 1 clinical trial on a drug that's in development that targets that particular genetic mutation. And so I would just, second what Kathy said. It's critical to share these data.
Lori, why do 15% say no?
I think the same reason that was given to you earlier by one of the panelists. I think to some degree, it's a worry about privacy. It's a lack, perhaps, of understanding of what it means to share one's data, or a fear that that data will be used for purposes that are not consistent with that patient's beliefs. Yeah. We'd like to get it to be 100%, and having said that, it's very expensive because most of this is not reimbursed by insurance companies. Yeah. So we have to raise philanthropic funds in order to be able to offer this service to our patients.
And just to touch upon that a little bit more, We knew that Dana-Farber had a great data set for us because it was a competing data set, a competing trial with the one we were doing to sequence the genomes of all these myeloma patients. And so we knew that those were two good data sets because they weren't putting people in our study because they were similar. So that's where you want to combine it. But you can't just go to an academic center and say, can I have your data set? And I think that's the business model we learned, is you have to go to an academic center or whomever, frame a very specific question. And I also find that a lot of times by working with the machine learning companies, you learn. You can't just say, well, should we do maintenance therapy? There's 100 questions within that question. So you really have to work with a team to decide what data do you want, how do you bring it together, and who's going to spearhead the project. But I think over time, and going back to democratizing care, in myeloma, what we would really love is to have a database so huge that no matter what your subtype was, any community oncologist could go into the data set we're building that is genomic, clinical, longitudinal, and structured, and be able to say, based on everyone before you and that subtype and everything they did, here's where the outcomes were better. And at least let the community see that and at least democratize care so it doesn't matter where you are. Any community oncologist could figure that out.
That's great. Aligning incentives and obviously sharing data. We have a question. Yes.
Excellent panel. Really appreciate your comments. I'm Nina Shelson, an early stage venture capitalist with Canaan Partners. And in addition to the data access and sharing, never mind the plumbing that brings it all together from all the various different points of care, a couple other major bottlenecks that we see for precision medicine are access to medical geneticists as well as bioinformaticians. And I'm curious, particularly from Omran and Vijay, how you're solving for those issues and constraints.
Yeah, I mean, I've seen companies where they're attempting to scale these methods with, with telemedicine and approaches like that. I think it is a challenge, and I think compute can scale what we have, but can't create what we don't have. And my hope is that as the opportunities come with companies like Color, we'll start to see the opportunities for needing the genetic counselors as well.
One last question, quick. We have 1 minute.
Yep. Yeah, I'm Alan Sachs, Chief Scientist at Thermo Fisher Scientific. Kathy, at lunch today and again during this discussion, you've indicated if you could do it all over again, it sounds like you would have done something differently. Maybe expand on that a little bit?
I don't know. Looking historically, we started to build our own data set in myeloma when genomic sequencing was pretty high. So making a $40 million investment for that, I still think it was the right thing to do. One thing I might have done differently was when we actually built the whole data set out, we thought that we could build out a portal where all the scientists could be playing with it, and then we could build something out for the community, but two such very different needs, and we never got to the patient piece. So that's why we're really starting to work with new partners so we can say, build a huge data set, make it statistically significant, and create the plumbing and the hardware in a way that you can really create simple visualization for your academic scientists, for your community, and really for the patient as well, because we want to be getting them as engaged as we possibly can. But there's a lot of education that goes along with it. So I might have just done a few of those steps in parallel as opposed to the way we did it, because I feel like it's taking too long.
Well, thank you to the panelists. I want to say before we end is that, Othman put his money where his mouth is, or some expression like that. And each of you have a card for a free BRCA test. To truly democratize the test and give it to all of you. And hopefully you can spread the word about genetic testing, personalized medicine. The conversation will continue in the reception before dinner. But I thank each of you for participating, and we'll move on to the next panel. Thank you.